And in young children, that can happen in the small bones. And sometimes it can actually be visible inflammation. But as our bodies age, the sickling only happens in the longer, deep bones where that can't be visible. And it ends up being, as I'm probably the least well qualified to tell you, as our many patients have told us so poignantly earlier this morning, it ends up leading to this deep, intense, invisible pain that sometimes is misunderstood and can be undertreated. And this is a series of 3 pieces of artwork. And I was devastated to hear last week that this artist who created these really incredible works of art to reflect the pain that he had been experiencing throughout his life with sickle cell. He passed away, and that's Mr. Hertz Nazaire, passed away last week of complications of sickle cell. So, you know, on that very sad note, we think about how can we create hope for the future, hope for people living with sickle cell so that they don't need to be experiencing more pain than what their body is already subjecting them to. So I should say I had the great pleasure, along with Dr. Isaac Odami, of co-chairing the expert panel that was involved in crafting this handbook. We just got somebody who mute issue there. Perfect. So this, in fact, I won't go into it, but it's very interesting. It started out where it was meant to be a quality-based procedure. So it was going to be pay for performance. So where hospitals would be given these guidelines and then would be expected to implement them, and then that would be measured and their pay would come from that. Over the course of time after we created the document, priorities changed and the decision came to this being more limited to the clinical handbook. The scope of the content was exactly the same, but the implications for the organizations changed. Just again, something to point out. So this was published at the end of the whole process in December 2017. These names are very small, but just to highlight, we had, I believe, 25 experts from across the province, including hematologists, pediatric and adult, pain specialists, social work, nursing, and it was all overseen by the Provincial Council for Maternal and Child Health. The document is very long. It's about 60 pages, and peppered through the the dry scientific language and statistics are these blue boxes, which share some really deep and meaningful feedback that was provided during a focus group in July of 2015. I'm not going to go through the details, partly because we don't have a lot of time, and also because there just are so many of them, but just in terms of giving you an idea of what's included here. We partnered with the Ministry of Health to pull specific data about rates of emergency department visits broken down by different demographics, so age, sex, location of where the patients were coming. And we used those data to help us to decide what were going to be some of our key recommendations. So this is just an example of some of the background that was provided about, for example, the C-test, which is the scoring of triage. And one of the things that you've probably already been hearing today, and one of our focus is when a patient presents, how they get triage, so what severity their visit gets assigned, can potentially affect the whole trajectory of their care. Because if they're prioritized, if they're triaged at a low priority, then the speed with which the care they're receiving is going to be slower versus a C-task 2, which is the recommendation, where that's considered emergent and they're expected to be assessed quickly. And that number is what tells the physicians who they need to see first and who to prioritize.
Can I just interject for a second about triage? It's Mary. I'm the educator for the emergency department.
Yeah.
And actually, I just recently spoke to the provincial guidelines, and they're putting that in as recommendations. So they are looking at putting, because it's an anemia type of illness, that they're going to increase the severity, and it'll be reflected shortly in the triage guidelines.
Oh, that's great. Thank you so much for that.
No problem. Sorry to interrupt.
Okay.
Thank you.
Yeah, no problem. Okay. So one of the other things that we were able to do with these data was to determine where were patients, across the province. Were there certain areas where there were many more patients and certain areas where there were fewer? And mostly the numbers mapped onto what we would have expected based on population and diversity of those populations. But what we did see was that all areas of the province had patients who were affected and who were needing this care. And what was interesting was that some areas that have a lot of need and demand didn't necessarily have the focused services that patients would really benefit from. So while we were tasked with coming up with recommendations about how care could best be delivered for that pain presentation, the emergency department, we really did spend a lot of time thinking about, is that treatment in the emergency department in essence, that's kind of a Band-Aid. That's a quick fix, and we want to provide very compassionate expert care, but how could we do even better by optimizing patients' health to keep them out of the emergency department? So one of the things that we thought a lot about was how could we design care across the province to do even better. So this is very tiny. You can't read the words, but this is a bird's eye view of the flow diagram and some of the decision points at which teams in the emergency department are being nudged to determine what's going to be the best care for patients at each step. I'm going to go into this a tiny bit, just again, by way of example. So when we came right down to it, the recommendations were based on three main sources of existing clinical practice guidelines. There was the Canadian Consensus Statement, which is our national guidelines, the NICE guidelines, which are from the United Kingdom, and the NHLBI guidelines from based in the United States. And so as you'll see, and as I mentioned, and as Mary mentioned, this recommendation about assigning the CTAS level 2 was one. And then as well, in conjunction with that, the idea that, which is in some places feels like an aspirational goal, but this is all the guidelines are in agreement, a goal of receiving the first dose of parenteral, so IV analgesia. In most cases, that's opioids within 30 minutes of triage. And then some guidance, for example, for the nurses. What are some key questions to ask? How do we involve patients in that assessment and making sure that we've really heard them and understood what they're experiencing? And so while I've only showed you a very small snippet of the recommendations, they really focused around what you were seeing in this illustration, trying to intercept this cycle of barriers to care, ensuring that the clinician and the patient both have the knowledge, trying to destigmatize sickle cell, trying to destigmatize this idea of the opioid drug seeking. And while we didn't get into it in a great deal in this report, it was acknowledged of the work that we all need to do in our institutions and in our healthcare spaces on racism in healthcare. There was also a set of recommendations about what steps need to be taken for implementation, and highlighting a few down at the bottom here, including clinician education about the pain assessments, again, the CTAS, and then extensive education on best practices for nurses and doctors who work in hospitals with high volumes of ED visits of people in acute pain from sickle cell vaso-occlusive crisis will be required. So again, kind of whirlwind tour of this because we've got limited time and I want to leave a couple of minutes for discussion or questions at the end. But really, what are we trying to do here is we want to break the cycle. We want to bring in education and system improvement. And this work has been ongoing for a long time. Partners like SCD have been instrumental. Events like today are just so important to bring us all together so that we can together figure out ways to improve the patient and family experience, improve healthcare and provider and hospital education. And as well, we're thinking now on provincial, national, and international levels. I think today's event is really special and unique in many ways, but sets the standard for how a lot of the system improvement can happen. And it really involves our health systems working very closely with informed, activated patients, where everybody's working together as a team. There's not this hierarchy where you know, the healthcare system kind of just makes the decisions in a vacuum. We really and truly need to know what our patients, their families, and their supporters need. So I'm not going to go through this, except to say there are a lot of ways that we can think about implementing these changes, and a lot of the fruits of this implementation we're seeing in our presentations from the individual hospitals today. I'll just draw our attention again. There is a set of national consensus statement, which serves as clinical practice recommendations on not just sickle cell vaso-occlusive crisis, but on all aspects of sickle cell care. And I've shown this image before. I think for me, it really sums up what the experience of living with sickle cell and trying to obtain good care can feel like for folks, where the health issues can sometimes feel like an enormous boulder. And because of the barriers to care, it can feel like not only are you pushing this enormous boulder, but it feels uphill. So I think we all need to continue to help, as I say, many hands make light work. We can't take away the personal suffering that someone with sickle cell is experiencing, but in many ways we can work to help both prevent and treat compassionately when it does happen. So with that, I'll wrap up, and over to you, Dr. Brian.
Thank you so much, Dr. Verhofstadt. An excellent whirlwind tour of the clinical handbook. A fantastic timing, because it came up so often in the discussions this morning. So I hope that was a very helpful review for everybody who's listening in today. Please do put your questions in the chat or in the Q&A box. Now I wanted to again thank everybody who is attending today. We have such a special opportunity here to be speaking with patients, with family members, with friends, with community advocates, with healthcare providers all together, and a chance for us to really collaborate. I wanted to recognize as well that we have Mr. Delaney Hines, who's joining us this afternoon from Ontario Health. So I wanted to say a special thank you for joining us in this conversation. Madeline, we did have a question in the Q&A about the clinical handbook, and the question, it comes from Linda Waterhouse, and it's, is this to be both for pediatrics and for adult services?
Yeah, and thanks, Linda. And Linda, shout out to Linda. She's the social worker who works with us at our McMaster Hemoglobinopathy Clinic. So Linda, indeed, the handbook was meant to cover the whole lifespan. And really, because the standards of care, the expected best practices, really shouldn't change based on somebody's age. The pain and the complications can have some unique features across the lifespan, or the complications that can come on top of the pain crises. But in terms of the best practices for timing and associated investigations, and as well the need for very patient-centered intensive treatment of the pain, those things are all universal.
All right, thank you so much. And again, anyone has any questions, please put them in the chat or in the Q&A. If there's not time to address them right now, we will be having a larger Q&A after our next hospital session. And Madeline, if I could ask one last question before we do move on to the next session. Often in medicine, the question is what's next? And so with the clinical handbook, are there plans for how to keep this updated over time? Or what are the next steps in terms of guidelines for Ontario?
Yeah, that's an amazing question, Jennifer. And I would say when the handbook was developed and launched, Initially there was a little bit of, kind of uncertainty and confusion when the focus shifted from, as I had referred to, the quality-based procedure versus the clinical handbook. And it seemed initially as though there was a lot of energy and thought and planning into how to launch this information, how to spread it, and to share it. Overall, and there has been fairly good uptake, although it's been over the past, almost 4 years now. I think it has reached many corners of our province. To date, I'm not aware of any specific plan to update it or anything more that is on a schedule that's going to be happening. I know there has been a lot of focus from SCD and other patient organizations, including the Sickle Cell Association of Ontario, trying to look at that, trying to advocate within the government about, how do we make this, maximize the impact. And then I think your thought is really bang on. A lot of these things are going to be timeless, the principles of compassionate care, but how do we make sure that the content remains up to date, and that as the science evolves, how do we keep this document like a living document? And so those are important things for all of us to think about. And I'm looking right back at you, Dr. Brian. I think we need to be partnering with our emergency department champions across the province to look at how we can do that best.
Fantastic. Thank you so much. And I also love the expression, many hands make light work. And that is exactly what we're doing here today, right? Is to try to all come together with this shared goal. Thank you so much. So at this point, I'm going to hand things back over to you and to Dr. Ayurinde for our session with our next group of hospitals this afternoon. So thank you both very much for moderating this session, and I'm going to be listening and taking notes as we go.